Okay. All right, so participants are entering the webinar right now. We're going to give them just 1 minute before we start. Thank you, everybody. All right, good afternoon and welcome to our 12th episode of Pandemia. This series of webinars dedicated to inform you about COVID-19 and COVID-19 vaccines with a focus on the Hispanic community. This is a collaborative effort between the Latino Commission on AIDS and the COVID-19 Prevention Network. My name is Luis Alberto Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS, and I will be the host and the moderator for this webinar. We have been bringing you Pandemia for almost 2 years now, since July 2020. And through these almost 2 years, we have seen the evolution of the pandemic, and we also have seen the evolution and the response of science. Each episode of Pandemia has been adapted to what was happening at the moment when it happened. Therefore, today's Pandemia is dedicated to COVID-19 vaccines for children under 5 years old. Our presenter, one of our presenters today, Dr. Ligia Peralta. She was here before in another episode of Pandemia. She's a pediatrician, president and CEO of Casa Ruben, as well as a clinician scientist fellow at the Massachusetts Institute of Technology. Dr. Peralta is an active member of the HIV Vaccine Trials Network of the National Institute of Health. Currently, she leads a new initiative addressing the needs of individual recovering from COVID-19. In Dr. Peralta's presentation, we will learn about epidemiology of COVID-19 in children, and also if the last wave of Omicron had any effect on this population. We will learn about the differences between the different vaccines for children, the challenges in the process of approving the vaccines, and also the doses, the indications, and the contraindications of the vaccine in children. This time, we also wanted to include a period of life that is related to childhood, is what happened before we are born. So we have a presentation. The first part of the presentation is going to be focused on how COVID-19 could have an impact on the normal development of children before birth, and also how COVID-19 vaccines can have a positive effect in this time of COVID-19 that we live in children during and after birth. So this webinar will touch on COVID-19 vaccines in gestating and lactating women as well, and the effect on children. And for this, we have our other presenter, Dr. Carmen Zorrilla, an obstetrician and gynecology professor of obstetrics and gynecology at the University of Puerto Rico School of Medicine. During the COVID-19 pandemic, she spearheaded the development of a molecular testing program at the RCM, a phase 3 vaccine trial of COVID vaccine center with a 97% vaccination rate at the faculty, students, and staff at the University of Puerto Rico Medical School. She's a member of the scientific coalition named by the Puerto Rico Governor Pedro Pierluisi to advise on issues related to COVID-19 pandemic response to further incorporate the input sciences into public policy. This webinar, like every other webinar of Pandemia, will last an hour and will be streamed by Facebook Live on the page of the Latino Commission on AIDS. But it's also being recorded and it's going to be posted in our websites and our pages of social media. This webinar, as I mentioned, it's going to last an hour. I'm going to follow with 2 presentations after I finish with the introduction. And there's going to be a part of 20, 30 minutes about question and answers. So please write your questions in the Q&A box so we can read it for the presenters. And with this, I give the floor to Dr. Carmen Zorrilla, who is going to start the webinar. Let me pull up your presentation.
Hello, everybody. I'm glad to be part of this conversation, and I suggested that we start with pregnant women because this is the way we usually address children before they are born. We love them already. And so this is my message to you regarding what we know about pregnancy and COVID and pregnancy and vaccines. Let's have the next one. My key messages will be 4. 1, first of all, COVID-19 in pregnancy is more severe than among non-pregnant persons. Vaccination during pregnancy is safe and effective. Vaccination of lactating women is also safe and effective. and infants receive maternal antibodies and immunity when the mothers are vaccinated and also through lactation. So these are my most important messages, so that we certainly need to have this information spread to our community, because we do have a lower rate of vaccination during pregnancy at this point. Let's have the next one. As I just mentioned, COVID-19 infection is more severe in pregnancy and is associated to increased maternal and neonatal morbidity and mortality. And let's have the next one. These are just a collection of few articles that have been published comparing what we see among pregnant women versus non-pregnant persons who have COVID and what the manifestations are. And for example, let's have the next one. In a study of almost 19,000 people, pregnant persons, out of 869,000 individuals, they found increased rates of preterm birth, admission to intensive care, respiratory intubation and mechanical ventilation, and in-hospital mortality among pregnant women. So in equal situation and equal comparisons, women who are pregnant and have COVID have a worse outcome themselves and their infants because of the pregnancy. Let's have the next one. In here, although it is a busy slide, I just want you to focus on the squares on the right side. These are meta-analyses, and these are 42 studies with almost 438,000 pregnant persons. They found preterm labor, gestational diabetes. We don't know the mechanism why pregnant women who have COVID have increased risk of gestational diabetes. We don't know exactly what goes on, but COVID affects multiple organ systems, and that might be the reason. Increased admission to intensive care unit, increased incidence of preeclampsia, low birth weight, and stillbirth. So there's a concern that pregnant women who have COVID not only have, again, admissions to intensive care unit, but also that their babies might die in utero and are born there. Next one. So in contrast to what we see with COVID infection, what do we see with vaccines in pregnancy? We know that we had a lack of information when we started having conversations about vaccines. We sort of said, well, we don't know what happens with vaccine among pregnancy and during pregnancy, so let's wait and have more information. And I think this message was ingrained in our community. And even when we have the information now that vaccines are safe and effective during pregnancy, people got that initial message that we didn't know and we have to wait. And so right now, most of our community think that they should be waiting after the pregnancy to get their vaccine. So I'm gonna show you some articles and some information regarding what we know about the safety and the efficacy of vaccines in pregnancy. And there's a study on 35,000 vaccinated pregnant persons who showed safety and no increased risk of obstetrical complications compared to the unvaccinated. Certainly people who are pregnant have complications, that's part of the pregnancy, but they don't have more complications or different complications just because they got vaccinated. Let's have the next one. These are, again, and you will have access to this slide. These are different studies that have been published on the safety and efficacy of vaccines, COVID vaccines in pregnancy, particularly the mRNA COVID vaccines, such as the Pfizer and the Moderna vaccine. Let's have the next one. Here we see the blue bars are pregnant women and the light blue bars are non-pregnant persons. And you see most of the symptoms associated to vaccinations are more or less the same. In fact, there's one study that actually showed that women who get vaccines in pregnancy have lower fever and lower side effects in terms of rates than people who get the vaccines when they are non-pregnant. Let's have the next one. So this is why the CDC some time ago recommended vaccination during pregnancy and lactation. And so this is a recommendation based on that evidence that we show that COVID is worse in pregnancy and vaccines are safe and can save lives, not just of mothers, but also of infants. Let's have the next one. So one thing that, one piece of information that is very interesting and important is that when women get vaccinated during pregnancy, their immunity is higher than when they get vaccinated or when they get the infection. For example, some people think that when you get the infection, you're gonna be immune to COVID and that's gonna be okay. But if you get the vaccine, you get higher levels of antibodies as if in contrast to if you had the natural infection. Let's see the next one, the next slide. It's a busy slide, but you can see these points with different colors. Those are the levels of antibodies comparing non-pregnant person, pregnant persons, and the yellow is lactating women. And you can see on the left side, you can see the antibodies when they had the vaccine. In contrast, on the right side of each of the smaller graphs, you see the antibody levels when they had the infection. So there, certainly vaccination increased the levels of all the different types of antibodies that were measured, particularly on this study. Let's have the next one. Again, they measured antibodies in cord samples. That means when babies are born, in the cord blood has fetal blood. It doesn't have mother's blood. When you measure cord blood, you're measuring what's in the baby. And they were able to measure antibodies in the cord blood of women who had been vaccinated during pregnancy. Therefore, the immunity that women have during pregnancy when they get the vaccine is passed to the fetuses or to the infants through the placenta and the cord. And we know this because influenza vaccine, tetanus vaccine, most of the other vaccines that we administer in pregnancy, they serve that purpose. We want to vaccinate the pregnant person so that immunity is transferred to the infant. Let's have the next one. In addition to having immunity during pregnancy while in utero, babies that are breastfed acquire antibodies because they are expressed in maternal breast milk. Let's have the next one. Again, that's another graph. And the interesting thing about this study is that they measured breast milk antibodies on women who had 4 different types of vaccines. The upper you see this graph, this Kaplan-Meier graph, where you see these 2 lines that get to the top very quickly. One that looks like very dark and one that looks like yellow. And then you see 2 other lines, one that is blue and one that is looks like brown from this where I am. These are the mRNA vaccines versus the other 2 vaccines, the AstraZeneca and the Janssen vaccine. So vaccines that are mRNA induce higher levels of antibodies that are expressed in breast milk, in contrast to the other types of vaccines. Next one. Our communities and mostly pregnant women are concerned that if they get the vaccine, they might lose the pregnancy. So these are 2 studies that were published regarding a miscarriage risk related to mRNA vaccines. And what they found is that mRNA vaccines do not have increased risk of miscarriage. And let's see in the next one, a graph where we see a curve, 4 curves. You see there 4 curves. One is blue, one is gray, another one is yellow, and another one is orange. The orange and the blue are miscarriage rates among the general population as published in the literature. And the gray and yellow are the miscarriage rates of women who had received vaccines. So therefore, vaccines are not associated to increased miscarriage rates. The rates are the same as the miscarriage risk of people who are part of the general population. Pregnancies have, not all pregnancies are carried to term, and this is why we have this information. Let's have the next one. So as I was mentioning, our community felt that they needed to wait till we have more information on vaccines in pregnancy, and this is why we have lower rates of vaccination during pregnancy in the US. You can see the next one is a graph of different rates of vaccination among ethnic groups and communities in the US where Hispanics have lower vaccination rates than other groups in the US. And it's also associated to education level and other areas where you live. So next one, I believe that we have an opportunity here to disseminate information that is supported by science. Again, let me repeat the messages. COVID is worse during pregnancy. Vaccines during pregnancy are safe and effective. They also induce antibodies and protection that is transferred from the mother to the fetus, and the babies are born as if they were vaccinated. And also we don't have vaccines for the immediate, within the first 6 months of life. So it's important for pregnant women to get the vaccines in time before they deliver. That's my last slide. And I just wanted to show a nice photo of San Juan, Puerto Rico. And I know we're gonna have a very nice conversation at the end. Thank you so much.
Thank you, Dr. Soria, for an incredible presentation. And now we're going to go to the second half of the presentation with Dr. Peralta. The floor is yours, Dr. Peralta.
Thank you so much to Dr. Carmen Zorrilla, a wonderful colleague, investigator, and someone who I had the honor to co-chair the Latinx committee for the COVID-19 Prevention Network. It's lovely that we are talking about this in the studies now. As we know, we had spent quite a bit of time reviewing data. Also, thank you, Latino Commission on AIDS, for doing 12 of this, and to our COVID-19 Prevention Network colleagues who are helping us out, spreading the news about what we know now. So the next one, I'm going to show just a little bit about the epidemiology. Many mothers still think like their kids who are small, they will not get COVID-19. So I would like to touch a little bit on the Omicron and how that has impacted them and the new data that we have as of this month, a few days ago. Also to review COVID-19 vaccines, the approval process, especially for this population, some of the questions about why delays. And also the biggest point, I think, is equity on vaccination as we approach this next chapter for the younger ones and implementation of the vaccines. The next one, just to set the stage, the American Community Survey data of 2019, which is what we have, estimates that 19 million children under the age of 5 are in the United States, and they're 6% of the US population. But interestingly enough, they're a little bit over half are Black and brown, they are ethnic minority children, plus 25.9, 26% are Latinos. So this is interesting because now we have to design programs that really are going to address the issues about minority children and also those primarily who are sponsored, almost half of them, 41% with public insurance, Medicaid or CHIP, and 4.5% underinsuring. How we are going to do that? So the next one is, what have we known about the burden of pediatric SARS-CoV-2 or COVID-19 infections? Most interesting, we have many unanswered questions. We have very few studies on pathogenesis and spectrum of disease. There are no pediatric data from placebo-controlled randomized clinical trials, and there's limited data on observational studies on how to treat COVID-19 in kids. But what we know is the long epidemiological studies demonstrate that severe manifestations of acute disease are much less than what happens in adults, right? However, the good news is a small percentage of children with COVID-19 will require medical attention. So the hospitalizations are less, but the ICU admission rates for those hospitalized are comparable to the adults. So they get sick. And this is important to know. Next one, please. Because we know just a little bit about who are the highest risk of severe disease. Those children with history of complex medical needs. For example, there are many mothers who have kids with neurological impairment or developmental delay, and they feel like, oh, maybe this is going to cause some harm on my child. It's the opposite. COVID definitely could have a higher expression of severity on those children, the same as Black and brown population. These children are 3 times more likely to be hospitalized than white children. And of course, the unvaccinated teenagers hospitalized 10 times the rates of vaccines. So one of the areas that I think is important to mention is that we don't know how to predict which children will develop severe COVID-19. That famous multi-system inflammation, 30% of these kids hospitalized with the inflammation had no underlying health condition. That's why vaccination, like we just said earlier, is not only safe, but also prevents what we don't want, our children to go to the hospital or die. So what do we know about Omicron? This is the latest. Omicron surge demonstrated that children get sick, they're vulnerable, and they can get to the hospital. Look at that graphic right there. The first part of that graphic, all in white, is all about pre-Delta variant. Then a little bit on the bluish, you see the Delta variant period. And then the last one, when you see the high peak, this is the Omicron. Right at the beginning of January, just before January to now, the Omicron predominant period peak was 5 times during this period that compared with the Delta or the pre-Delta time. So this is very important because 63% of those infants and children had no underlying medical conditions at all. It's not the kids that we talked about that had some condition like diabetes or sickle cell, etc. No, 63% of those infants and children had no underlying medical condition. And look at the far right of this peak, 5 times higher than what we had, especially in the younger ones, 6 to 23 months, and then the under 6 months. The next one. So despite reporting less frequently after the summer of 2021 or dropping metrics after the 2021 summer, but also because now we are doing more testing at home, right? And not necessarily capturing that. In the last 2 weeks, from that period of the end of February, from the 24th to March 10th, there was a 1% increase in the cumulative number of pediatric COVID-19 cases. This is the time when we thought everybody was getting, under control. We learned that kids were extremely vulnerable, and that the vaccines applied to the 5 to 11 years of age have saved many of these children from hospitalization and severe complications. Next one. So how different are these vaccines? When we talk about the 5 to 11, we had all this data and we reviewed the data before, but what about this one, this particular vaccination for children under 4? It's pretty much the same RNA vaccinations that Dr. Zorrilla already mentioned. But we know that from the 5 to 11 years of age, with the emergency authorization for that particular age group, that we were able to reduce severity of illness, we were able to reduce hospitalization and death, and that the vaccine was safe and that kids tolerated that pretty well. So let's take a look at next one. Why the delay in the, reporting the data? And many of you remember that the FDA on February 11th issued a notification in terms of delaying the meeting from February 15th, asking for more data. So the good news is that the process is as rigorous as it has always been, especially for this population, right? That no one has cut any corners. But why did it take longer? Because Omicron surge happened at the time of the clinical trials, when all these kids under 4 were participating in these clinical trials. There is a lot of information there. And also there was increased hospitalization. So the FDA, as a public health agency, requested from Pfizer, the only one, ahead of the pack, data on the 2 doses from the ongoing study. That's basically what happened. And the review was extremely helpful, because what it was demonstrated was that there were no concern about safety whatsoever. The infants tolerated the vaccine extremely well. There was very, very little local reaction, if any, and very few of them had a little fever, maybe fatigue. But what they wanted was additional data to look at how effective it was, in particular for the children of 2 to 4. From ages 6 months to 2 years of age, the data looks pretty good in terms of efficacy. From the ages 2 to 4, when they compare that with older children, they wanted more information, especially in terms of efficacy at the time of Omicron. And instead of just accepting a 2-dose, they wanted, or they requested, more data with a booster vaccination. So there was a lot of debate about why Pfizer, which is the only company ahead of the pack in doing that kind of clinical trial, why don't they change the dose from 2 to 4? And the rationale was to keep the dose as is, because children tolerated that very well and the infants did beautiful, and add the booster and then look at the data a little longer. And this is what the data is expected probably to be reviewed after April or so, or by May. Hopefully we'll have better data. So the next one is looking a little bit at the difference between the formulations of the COVID-19 already for children. Remember, the only one right now approved for fully approved is the Pfizer for 12 years and older. Then from 5 to 11 years of age, there is emergency authorization. And then the future product is going to be from 6 months through 4 years of age. So how different is this product? Well, the first thing is the dose. The full dose from 12 years and older is 30 micrograms. So that's the baseline. So for the 5 to 11 years of age is 1/3 of the dose. And for the little ones, the 6 months through 4 is 1/10 of the dose. Those are the doses that were in pre-trial found to be well tolerated. And again, what we are looking now is really what happens to that after the 2 doses with the booster for the kids who are 6 months to 4 years of age. So stay tuned. However, one important issue is that the formulations are going to be different than the kids are going to have. The 5 to 11 are going to have a different dose than the 6 to 4 years of age. And this is something that when the families, right, get the vaccination, I think it's important to explain that, because one of the issues is trusting what vaccine my child is going to receive, especially based on some of the news that people with less experience or agencies with less experience in vaccinating kids have been able to sometimes not necessarily have the correct dose. Interestingly enough, for the 6 months to 4 years of age, most of those vaccines are going to have in pediatric practice or handled by individuals who are very familiar with infants. And I think this is going to be one of the interesting pieces of implementing this next phase of vaccination for COVID-19. So the next one is, what are the indications? Basically for all children within that range. There are no exceptions right now. The children, we need to wait for the further data in terms of, who are the highest risk within that cohort. But right now we know for the older kids, those with neurodevelopmental conditions, congenital conditions, sickle cell, allergy, diabetes, heart, lung, and immune conditions are pretty much a higher risk of COVID, and they would greatly benefit from getting the vaccinations. The next one, there are no contraindications right now in the preliminary data in terms of, these kids not getting the vaccine, especially infants. The only contraindication is severe allergy to any vaccine ingredients, or someone who had an allergic reaction to the first dose. But the only ingredient in the vaccine found to elicit allergic reaction is the polyethylene glycol. And many parents are familiar with this component, this ingredient, because it's in the Miralax. This is what children are given for constipation, in many cases as a first line medication to help them with their constipation. So, but that is rare, and if the child has had some allergies to Miralax, that's going to be well known to the parents. So in terms of adverse event, we already mentioned that in that cohort from 6 months to 4 years, they tolerated this vaccination pretty well, and some of the side effects were similar to the older kids. I'm going to skip the myths so we can have a conversation about that, but the next one is about the vaccine setting. As we are approaching kids who are not in school, this is going to be an interesting time when pediatricians, who are already kind of the trusted source, and this is something that has been well studied already, but they're trusted source for information for their children, of course, but also about COVID-19 vaccines for children, they will likely play the largest role. And as a pediatrician, I can tell you one of the things that we need to be very attentive to is really, how this is going to be implemented and what do we need to do as clinicians and clinicians in primary care to be able to increase the access, especially because we're dealing with half of this population, children of color, of ethnic minority youth and infants, compared to 40% of the US population in general. So we will need not only incentives to the parents, but we would need to be able to educate them. And this is going to take, which I predicted for the 5 to 11 too, more time to be able to take the time to explain all the differences and the safety issues related to this vaccination to parents. So with that, I would like to finish with an example of how we are preparing based on what we have learned from doing pediatric and family vaccinations in the community and as a pediatrician. From the 5 to 11 years of age, we have been able to innovate, taking the trusted source, right, which is the pediatric clinic, to the community after hours, and also at places like churches and other places like after school programs and after school hours, where we can go to be able to have the children vaccinated in a safe environment, in a trusted environment with trusted providers. So with that, I would open to questions, and I would just close with the next one in terms of summary. Omicron taught us that hospitalizations for younger children occur, that increased 5 times, that 63% of them had no underlying conditions, that COVID-19 vaccines approval process continue to be rigorous, and that more data is better, especially in the time of Omicron when all these hospitalizations happened, that vaccine formulation and dose is going to be different for the younger children than from the 5 to 11, and that the schedule of vaccination will depend on the data that we get and also, the approval process, but that implementation of vaccinating infants and children who are not in school will require innovation in our part, community effort with the pediatricians and the local providers to address the access to vaccinations. Thank you.
Thank you, Dr. Peralta, and thank you, Dr. Surya, for the presentation. So now we are going to go to the questions. There is a question here from Marisela Olivas. She says, many families are already behind on child well visits and up to date to other vaccines. Being so bombarded with COVID vaccine information, how do we get them to think about the COVID vaccine as another normal childhood vaccine if possible?
Excellent question. This is why the Committee on Immunization for the Centers for Disease Control review also how we can incorporate COVID vaccination into the routine childhood vaccinations. And remember at the beginning of back in November, when we started vaccinating children, it was like you start, with the routine vaccinations, then follow with COVID, but you don't mix. Now everything can be done together because of the safety of the vaccines. So we also know that combining vaccinations for children has been advantageous in terms of how they respond to vaccines in general, and their immune system have a very, very strong response and robust that could be beneficial for the children as well. So let's talk about combining vaccines and routinizing this so we can stop the pandemic.
Luis, we cannot hear you.
I'm sorry. It always happens. The doses right now are like for children between 5 and 11, from 12 to 16, and 16 to adults, right? So what happened with the vaccines are given to a child that is 11 years old, for example, and all of a sudden he turns 12, or if it's 15 and turns 16 in the middle of the two vaccination doses, and doses are going to change, or how do we do that?
Yeah, we have great recommendations too. We have been doing this massively. For example, and the CDC has been very clear that when you start the vaccination, the recommendations are by age, not by weight. I have had patients who are really tall and well developed at 11. However, we go for the recommendations now in terms of given the vaccination from the 5 to 11 at that age. And if they turn 12, we give the second dose as exactly the same as the first dose. We don't change from 1 month to the other because they turn 12 all of a sudden. And again, there are only 3 formulations because we only have one mRNA vaccine on the head of the pack, which is the Pfizer. So everybody above 12 gets the same vaccine. Okay, that's part of the development. So from 5 to 11 is 1/3 of that dose. And what is being studied right now and the preliminary data was 1/10 of the dose. So it's a very different dose because it's from 30 microgram to 10 microgram for the little ones, the infants.
Thank you. Dr. Zorrilla, I think you mentioned that when a mother is treated with vaccines for COVID, the baby is born with immunity for COVID-19, right? So is this going to be considered also in terms of when the first dose for babies under 5 years old are going to receive, are going to be indicated? Like how long is the immunity that we are born with, that they are born with, going to last, and if it's going to interfere, or so it be determined when to put the first dose?
So right now we have information that transplacental passage of immunity happens. And we also have information that immunity on infants lasts about 5 to 6 months, more or less the same as in adults. So, and in spite of that, if a vaccine is approved for infants less than 6 months old, it should be administered when the CDC approves that dose to be administered. I don't think that if the mother was immunized during pregnancy, that will change the timing of vaccination for the infants. But it will not last forever. It lasts about 6 months, which will give families a good opportunity to protect their children.
I would like to add something to that, to Dr. Zorrilla's comment in terms of, there was just a letter in the last, for JAMA about a brief study done in Boston about looking at antibody spike in infants after vaccinated mothers. And it's exactly what she said. It's not only we have those studies before, but now we have during this time of Omicron, and found that the majority of the infants born to COVID vaccinated mothers had persistent anti-S antibody at 6 months. So it's important because the mothers say, okay, you just say that because no, the studies are there. And this is what they want to see, that other families have, experienced this, that they have gone through the same in terms of protected the babies. But compare with infants born to mothers with SARS-CoV-2 infection or with COVID-19, sometimes the duration doesn't get to 6 months. And this is one of the things that we'll see more data during this Omicron.
Do we know if children also are going to receive boosters? Like we do.
The 6 months to 4 years is very likely because that's why we needed more data. The response from the 6 months to 2 years was robust and was pretty good. Optimal, I would say, with the 2 doses, but those who were 2 years to 4 years, the response was not equal to the older children. Therefore, the booster is the next phase of this clinical trial, and that's the data that we all are waiting for to be able to present it again to FDA.
The side effects of the vaccine in children are the same ones that we had when we were vaccinated?
They're similar to adults, except that children have been wonderful in terms of just having very little of systemic, and part of that is probably the dose. Remember, it's a different dose than what we use for 12 and up. But even at that age, they have tolerated this very well, mostly with local reaction, like the soreness of the arm, and I would say that a little bit of fatigue, sometimes slight headache or feverish. Very similar to when we give other vaccines for routine pediatric vaccinations. So it's not any different. And I just have to say this, but many of the children who come to the office say, my mother had a harder time than I did, meaning that they were making fun of the mother or the father because they thought that they didn't tolerate the vaccine as well as they did. But most of them saying, we did very well. We had no trouble. We didn't miss any school. We didn't miss any activities. And give me the second one. So we have had a much better tolerability with those doses. And that's why I think it's important to know that the company, for example, preferred to use a booster, right, for the little ones, for the infants, than just augmenting the current dose that they're using, which is 1/10 of the actual dose for ages 6 months to 4 years.
So is only Pfizer going to be the one that produces vaccines for children?
No, Moderna is also on the run, except that Moderna is approved. In fact, today was the big news that is fully approved for above 18 years of age. So they're looking at the 12 and up. Remember that Moderna always goes behind because they started at a different rate and pace, but they are going for the approval of 12 and up, and then also looking at the 5 to 11. And I can tell you that children from my own family have participated in the clinical trials for Moderna, for the 5 to 11 and under 4. So it is coming, except that they are just at a different pace than Pfizer as a company is ahead of the pack.
I would like to add that there's other companies that are studying vaccines in adolescents and children. And again, they started late, but there's going to be other types of vaccines, not just mRNAs, for children and adolescents.
And this information is only for the United States, right? Just for curiosity, if there is any vaccines around the world for children, or just Pfizer as well and Moderna?
What's the question again?
Like the information that we're presenting here is also for United States of America. So same as in adults, right? Like I know other countries and other laboratories have created different vaccines for adults. Is the same happening for children as well? Just a curiosity.
There are other companies right now, including the Sinovac in China. They are rolling the clinical trials as well. Remember, the approval process is very rigorous. It also goes through the WHO, etc. But definitely that is coming, and there is more than one company going in the run for that. At the moment, is just to be very clear for us in the United States, for children in the United States, the two companies that are going again ahead of the clinical trials are the two mRNAs at this point. But we are hopeful that the other vaccines, more kind of standard vaccines, will be available for many reasons. And one of them is, like Dr. Zorrilla said, I mean, we need to immunize many, many children, but we also need to immunize them in a very easy way. Like when, if we need to have mRNA vaccines are very well, we had to refrigerate them, right, for protection, etc. So we are eager, to use other vaccines that are easier to manage in those kind of practices. Remember, outside of this country, many of the immunizations happen in the countryside or community sites where refrigeration is not necessarily there at all times. So that's why we are so eager to see other vaccinations and vaccine trials for other type of vaccines.
I don't have any other question on apparently the audience today. You have time. You still have a few more minutes. If you want to ask a question, please write it down either in the chat or in the questions and answers box. In the meantime, I mean, we can, anything you want to add, Soraya or Peralta, before we finish?
Certainly, I'd like to add that the topic is so important and it's essential that we include this conversation with our communities, not just vaccinating adults, but also children and pregnant persons. We want our communities to be safe. These products are safe, and we need to convey again the message that our communities need to be protected. And we have seen disparities in access, and these vaccines in the US are given for free, and there's many places where they can be administered, so there shouldn't be any concerns with anybody in terms of getting that vaccine and being noted.
I would like to quote Dr. Zorrilla, who said, "We love the baby before they're born." This is very important. We love the mom and the baby. If we are advising on this, if we are putting all our resources on making sure that no corners are turned, that everything is as rigorous as ever in terms of the clinical trials and looking at the data, it is very important for our community to hear from us, not only in our practices, but out there in the community, that these vaccines are safe, and that these vaccines really are saving not only lives, hospitalizations. Look at the rates during Omicron. Look at what happened to very little children who are the ones who had no access to vaccination at that time because we didn't have anything ready for them. And look at the peak 5 times. This is the time when we need to think, let's normalize our lives. And also, like Dr. Zorrilla said, it's like there's so much information and so much confusion, but people forget that children have suffered a lot, and mothers too. They have missed many activities. They have suffered mental health issues because of isolation. They have missed school. They have missed incredible opportunities for learning and socializing and being part of the normal development of a child. This is the time when we need to do that for them.
Thank you very much. With no more questions from the audience, just they are asking for the presentations. We will send the presentations by email. And with this, we are finishing the webinar. Again, without saying thank you again to Dr. Peralta and Dr. Zorrilla for collaborating with us in this episode of Pandemia. And thank you all who attended today as well. And we'll see you next month on the episode 13 of Pandemia. Bye.
Bye, everybody.